Assalamu alaikum everyone. I'm Dr. Samiullah Khan, resident of urology. Today the topic of presentation is GU tuberculosis, genitourinary tuberculosis. Learning objectives are epidemiology, etiology, renal tuberculosis, ureteric tuberculosis, and bladder tuberculosis. Short introduction. Tuberculosis can affect any organ system of the body, including the GU tract. It is mostly caused by the acid-fast bacilli bacteria Mycobacterium tuberculosis complex. Mycobacterium tuberculosis and Mycobacterium africanum infect only humans, whereas other infects humans and additional mammals. Epidemiology. The WHO estimates that 1/3 of the population is infected with Mycobacterium tuberculosis complex in its latent form. The frequency of GU involvement among patients who develop TB varies significantly depending on the population studied. In the developed countries, GU-TB has been found in 2 to 10% of the patients with pulmonary TB. In contrast, the frequency in developing countries approaches 15 to 20%. In the developing world, the GU tract is the second most common extrapulmonary site after lymph nodes. Initial mode of transmission of tuberculosis is via the inhalation of the aerosol, infectious aerosols, and they reach up to the alveoli and taken up by the alveolar macrophages. At this stage, some of the infected Mycobacterium tuberculosis bacteria are either killed or escape by killing and begin to replicate and establish an infection, where bacilli spread to hilar lymph nodes and hematogeneously to the distant organs. Hosts attempt to contain Mycobacterium tuberculosis infection by forming a granuloma. Granuloma of tuberculosis is basically consists of a fibroblast, Mycobacterium tuberculosis, the caseous necrotic tissue, epithelioid cell, and multinucleated giant cells. Development of GU tuberculosis. There are 4 means by which GU TB develops. The principal route is via hematogenous spread. The typical sites for the GU seedling are the kidneys and the epididymis. Ascending or retrograde infection through the urinary tract is the second most common route of infection. Bladder irrigation with BCG. Contagious spread from other organ systems like spine, sauce. Direct inoculation is very rare. Clinical manifestation. The GU tuberculosis usually presented with very non-specific symptoms, and renal TB, for example, can be progressive and destructive but symptomatically silent until it extends into the bladder. The typical TB constitutional symptoms of the fever, weight loss, night sweats, and malaise are present in fewer than 20% of the patients. Up to 50% of the patients with GU tuberculosis have only dysuria on presentation. 50% have storage symptoms, and 33% have the hematuria and the flank pain. Renal colic occurs in fewer than 10% of the patient and corresponds to the passage of necrotic papillary tissue, clots, stones, and caseous phlegmon in patients with severe pyelonephritis. Typically, laboratory findings include sterile pyuria with or without hematuria. This combination is found in more than 90% of the tuberculosis patients in developing countries. The kidney is the most common site of GU tuberculosis. Renal infection is progressive and highly destructive over time. The pathological findings in the kidney vary greatly depending on disease severity. Renal histology shows granulomas, which are sometimes caseating. Other microscopic changes in the kidney include glomerulonephritis from immune complex deposition or amyloidosis secondary to the TB, mildew tuberculosis. When the renal infection is the outcome of widely disseminated TB in multiple organ systems, hematogenous spread of high number of bacilli lead to innumerable small pale clumps of granulomas that look like scattered millet seeds on gross pathological examination of the kidney. This is the mildew tuberculosis histological specimen of the kidney, look like very calcified kidney with caseous necrosis. This form of disseminated TB is known as mildew TB and carries a high risk mortality. In the kidney, the milia can be found studding the renal cortex and medulla and do not usually affect renal function. In the more localized infection of the kidney, tubercle bacilli become lodged first in the periglomerular capillaries. Granulomas form in the renal parenchyma and coalesce. When they caveates with necrotic material form, they result in frank abscess, chronic pyelonephritis, parenchymal and papillary necrosis. Sinus tract may emerge in the flanks. As the infection advances, the calyces become inflamed and eventually distorted, resulting in calyceal distortion, dilatation, stenosis. With enough disease progression, the kidney becomes non-functional, a process called autonephrectomy. There are two types of autonephrectomy. One is the caseo-cavernous type and other one is the fibrotic. In the caseo-cavernous type, the viable tissue is totally replaced with the granulomas and cavities are filled with the inflammatory exudate. And in the fibrotic tissue, kidney, autonephrectomy, severe scarring and calcification results in a shrunken small kidney. This is a CT scan of a patient.
So this is a CT scan showing the calcification and whole the kidney, and the term used for this is putty kidney, which occurs in cases of advanced TB when the whole renal parenchyma is replaced by calcified granulomas.
Ureter. TB in the ureter occur via descent of infection from the kidneys. As bacilli pass in the urine through the ureter, granulomas can form along the walls. Infected calculi can also descend and lodge in the ureter. The ensuing inflammation leads to scarring and strictures, commonly in the distal end of the ureter at the VUJ. Stricture can also occur throughout the ureter in pan-ureteral fashion, leading to a beaded corkscrew appearance. This is a contrast image of the beaded corkscrew ureter as seen in the picture.
So when there is patchy inflammation in the ureter, then the beaded appearance occurs. When there is inflammation, there is scarring and it causes narrowing of the lumen, and ureter appears beaded in antegrade films or the urogram films. When there is whole, the ureter is inflamed and replaced by scar tissue, then it's a lead pipe appearance. When whole the ureter is, there are loads of peristalsis in the ureter. So this is the typical beaded appearance of the ureter.
Urinary bladder. Descending infection to the bladder usually begin near the ureteral orifice and spreads along the lymphatics to the other areas. Similar to TB in the ureter, bacilli implant in the urothelium and causes a patchy cystitis. Ulceration may develop in areas where large granulomas coalesce. The dome of the bladder is the most affected site, whereas the trigone and the neck usually remain normal. Mucosal inflammation, friability, and hematuria all follow. Urinary frequency, urgency, pain, and dysuria become prominent when the bladder capacity shrinks to less than 100 ml. Severely contracted thimble bladder, a small capacity bladder, capacity of less than 20 ml, as shown in the picture. Small capacity bladder with a contracted fibrosed left side of the bladder. Diagnosis of GU tuberculosis. In developed countries, the primary goal of the diagnostic workup is isolation of mycobacterium tuberculosis complex in culture for drug susceptibility testing, because up to 20% of the GU TB occurs concurrently with pulmonary TB. It is useful to also assess for the presence of pulmonary disease.
So to reach the diagnosis, the most important thing is the detailed history and examination. What question should be asked in the patients with to suspect genital TB in the history? Anyone of you? Okay, that's good. और क्या पूछ सकते हैं? Family history is very important. Contact history is all the and history of travel, like in Western countries, when there is history of travel from the countries where the TB is endemic, it is also very important. And other known the symptoms specific to GUTB, like urinary symptoms, dysuria, intermittency, and which occur for prolonged period. With this, the urinary examination showing sterile pyuria, especially with RBCs. So these are all the symptoms. And what about the examination findings? What should you examine? What systems you should examine the patient with GUTB? Yes, pulmonary, because most of the pulmonary patient with GUTB has concurrent pulmonary TB. Lymph node examination, okay. Okay. What else? Abdominal examination should be done. In cases of advanced tuberculosis, there may be sinus trach formation in the flanks, and also one should examine the scrotum, because the second most common site of GUTB is epididymis, and there may be epididymal swelling, tenderness, beaded appearance of the vas, and in advanced cases there may be sinus formation in the posterior surface of the scrotum. These all are the examination findings you should be considered in mind.
The current gold standard for the diagnosis of GUTB is the urine acid fast bacilli culture. First, void urine is the best sample because urine is the most concentrated at that time. 3 to 5 urine samples on consecutive days should be collected for maximum yield. These should be cultured immediately after collection because prolonged exposure to urine acidity can retard mycobacterial growth. The sensitivity of urine AFP culture is as high as 80% when done in this manner.
So this 80% of sensitivity is usually in cases where when there is controlled collection and examination of the urine. In center like ours, when we discuss with our ID colleagues, they say the sensitivity even 3 to 4 samples of urine culture is around 30%. So the clinical suspicion and other findings should be considered in mind while evaluating the exam findings.
While taking the sample, you should take the terminal urine also. टर्मिनल जो यूरिन होता है उसमें ज्यादा चांस होते हैं कि टीबी पॉजिटिव है.
Yes.
लास्ट जो few drops होते हैं.
Yes, and how the urine should be collected in patients. But when you are advising the patient to collect 3 samples of morning void, what you should tell the patients when it should be collected? Yeah, the collection should be in the first morning void, because in the morning time the urine is concentrated and there are high yields of the collection of the acid fast bacilli at that time. And why 3 to 5 samples should be taken to detect the acid fast bacilli? Because there is episodic shedding of acid fast bacilli in the patient with GOTB, and there in one sample there may be false negative results, and 3 samples there is more chances to get the acid fast bacilli cultivated. And what are the culture media which are typically used to grow the bacteria? Yeah, Lost Jensen is a classical media which take usually 6 to 8 weeks to grow the bacteria. What other other media are there which get result early? It is a stain, basically. I am talking about media, culture media. There are some other Middlebrook culture media and also Baptic which get the results earlier than classic Lost and Jensen media.
Nucleic acid amplification test, also known as GeneXpert, provides results within 1 to 2 days, aid detection in cases with low bacillary load, in which culture might fail to isolate the organism. The tests have reported sensitivities ranging from 87 to 96% when compared with urine. Non-sputum specimens such as urine contain natural inhibitors that interfere with DNA or RNA amplification process, potentially resulting in false negative test results.
So GeneXpert is the method which should be used in initial investigation of the patient with GOTB. It should not be used to follow up the patient after treatment, because the GeneXpert may be positive in patient with treated which are responding to the treatment, because the bacteria are present in these cases, and it may result in positive results.
Histopathology shows findings consistent with the TB in 38.3% of GUTB cases in developed countries and 21% of cases globally. Because urine cultures are sometimes negative, tissue biopsy can aid the diagnosis of tuberculosis. Although mycobacteria are often not seen, the finding of caseating granulomas in the appropriate clinical context can help establish a diagnosis of GU tuberculosis. Ultrasonography. Findings are generally non-specific and visualization is not as clear as with CT or IVU, useful in pediatric or pregnant patients because of lack of the radiation exposure. Ultrasound is also less expensive than CT. Ultrasound can be used to evaluate the testes, epididymis, and with the transrectal ultrasound, the prostate and seminal vesicle, which will appear thickened. Ultrasound can also locate abscesses or cavities in the kidneys. Cystic lesion with septation suggests chronic infection. Focal calcification appear as highly echogenic areas with distal shadowing. Restriction of renal movement during breathing suggests a perinephric or source abscess. Like CT, ultrasound can provide concurrent information about the abdomen, such as presence of the ascites, lymphadenopathy, or mental caking. A primary use of ultrasound in GUTB is to follow hydronephrosis in patients who are receiving medical treatment, because fibrosis during healing can worsen urinary obstruction. Plain radiography. Initial renal lesion may appear as faint punctate calcification within the parenchyma. As TB progresses, the KUB film may show a globular calcification that corresponds to a tuberculous mass. Papillary necrosis appear as a triangular ring-like calcification in the collecting system. This is a X-ray KUB showing a very calcified shrunken small kidney, putty kidney. With fibrotic autonephrectomy, the KUB radiograph shows a small shrunken, calcified, cemented or putty kidney in which calcific rims outline the individual renal lobes. This lobar pattern is pathognomic for end-stage renal tuberculosis. A plain radiograph can also demonstrate renal and urothelial TB-infected calculi. Stones may take strange shapes as they form in the deformed and fibrosed renal pelvis. A stone in the shape of an upward arrowhead may indicate a renal pelvis that has been hiked up by contraction from scarring. IVU. IVU is the gold standard for imaging early renal tuberculosis. Initial erosive changes of the urothelium appear as loss of sharpness and edge irregularities. Calicial erosions have a moth-eaten appearance. Filling defect may be seen caused by the tuberculomas rupturing into the calyx or by the papillary necrosis. IVU can demonstrate medullary cavities that communicate with the collecting system. When a calyx or infundibulum is stenosed, contrast excretion by the parenchyma may fail, creating a phantom calyx in the location where the calyx should be visible. This is a picture of a phantom calyx. Urethral TB can manifest as a rigid, calcified, straight and pipe stream ureter that is tubular and lacks normal peristaltic activity on IVU. The ureter may also take on the appearance of a beaded corkscrew as a result of nodular fibrosis along the entire ureter. The pipe stream and corkscrew findings are highly suggestive of TB, particularly when seen concurrently with either kidney or bladder abnormalities. This is a contrast image of ureter showing the stricture at the distal end of the ureter. IVU can also detect non-functional kidneys resulting from the autonephrectomy as well as fibrous contracted bladder. On occasion, perinephric abscess might be suggested, particularly if there is restriction of renal movement with breathing or ureteral displacement on IVU. The most common finding on IVU, however, or obstructive changes resulting from scarring and distortion of the collecting system, calicial obliteration, infundibular narrowing, hydrochalicosis, segmental or total hydronephrosis, and hydroureter. Calicial dilatation and distortion will present a typical clover leaf pattern on film. UVJ junction obstruction is caused by tuberculous cystitis or stricture of the distal third of the ureter. The finding of hiked up renal pelvis with sharp angulation of the PUJ is known as Kirk-King's appearance on the IVU. This is the IVU picture, IVU, showing a hiked up renal pelvis with sharp angulation of the PUJ. CT urography, the most frequently used modality for imaging TB in developed countries. High-end multi-detector scanners can detect lesion as small as 3 to 4 mm. With the administration of IV contrast, CT can assess kidney function during different phases of excretion. Similar to KUB and IVU, CT reveals calcification, scarring, and signs of obstruction. CT is more sensitive than KUB in detecting calcification and thickening of the collecting ducts. Perinephric and source abscesses can be seen, as well as any pathology in lymph nodes, vertebra, spleen, or liver. Pathology in the prostate and seminal vesicle can also be visualized, including enlargement. This is a CT scan image of a kidney showing a well-defined hypodense lesion with small specks of calcification at the upper and the lower pole. Otherwise, the kidney function is preserved. Retrograde and antegrade pylography. It also helpful when IVU or CT cannot be done because of the renal insufficiency or contrast allergy. Can be used in conjunction with IVU to determine whether cavitations are obstructive or non-obstructive and whether they are in communication with the urinary collecting system or not. MRI can be useful in pediatric or pregnant patients to avoid exposure to the radiations. MRI can detect a single granuloma. Small lesions are hypointense on both T1 and T2 images. Larger lesions have central hyperintensity on T2 images because of the increased cellularity at the center of the granuloma. Large TB lesions can mimic malignancy, and it is not always possible to differentiate the two. A magnetic resonance urogram can be more sensitive than IVU in showing urothelial thickening and callicectasis.
So MRI is the investigation which is not very commonly used in cases of GUTB. It is selective for some small population. The most commonly used investigation are IVU and or CT KUB is most commonly used.
Cystoscopy and ureteroscopy. Endoscopy plays a limited role in the diagnosis of TB. Although it allows direct visualization of the lesions, findings can be non-specific. These include the local hyperemia, mucosal erosions, ulcerations, granulomatous masses, and irregularity of the ureteral orifices. Ureteral lesions may mimic malignancy. A golf hole ureteric orifice is suggestive of the TB. When found, upper tract imaging or endoscopy should be performed. This is a cystoscopic finding of showing a tuberculous golf hole ureter, severely contracted, withdrawn, and acute. This image shows a tuberculous ulcer hyperemic area in the bladder. These are the multiple images taken during the cystoscopy, and the first one is the surgical specimen of the kidney and the ureter, showing a calcified and kidney and ureter with strictured ureter. This is picture E, shows a typical golf hole appearance that is consistent with the TB. Biopsies should be performed when possible, especially if malignancy is up. If those with negative urine cultures, bladder biopsy can be 19 to 52% sensitive for TB treatment. The tubercle bacilli exist in environments within the host. These apply different pressures on the organism and cause it to exhibit different metabolic needs and replication speeds. The drugs vary in their activity against mycobacterium tuberculosis complex. Some are bactericidal and other bacteriostatics. Some drugs work best on rapidly replicating bacteria, whereas others are more effective against dormant bacilli. Before the start of the treatment, baseline measurements should include basal blood counts and liver and the kidney function tests. Patients should also be tested for the HIV and, when appropriate, hepatitis B and C. Directly observed therapy DOT should be employed to ensure medication adherence, compliance, and minimum likelihood of development of drug resistance strains. These are the drugs, first line anti-tuberculous drugs, and they are isoniazid, rifampicin, pyrazinamide, and ethambutol. And are the isoniazid, they may cause hepatic toxicity, peripheral neuropathies. Rifampicin can cause hepatic toxicity, flu-like syndrome, pruritus, drug interactions. Pyrazinamide can also cause toxicity, GI upset, and ethambutol, it can cause a red-green color secretions, urine, decreased visual acuity, optic neuritis. Treatment begins with intensive phase of 2 months isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by the continuation phase of 4 months with isoniazid and rifampicin only, or alternatively thrice weekly. Pyridoxine, vitamin B6 should be administered to minimize the risk of isoniazid-induced peripheral neuropathies.
So this is a typical regime of 6 months for the treatment of tuberculosis, but it may vary in certain cases, like it may extend to 9 months or 12 months depending upon the situation of the patient, like unable to get the negative AFBs result, and there is a presence of other sites of tuberculosis like CNS. So it may vary depending on the situation of the condition.
Ethambutol is added at the beginning of the treatment pending drug susceptibilities and is discontinued if the strain is found to be susceptible to the other first-line drugs. First-line drugs reach high concentration in the urine and work well in acidic environments. The intensive phase of treatments target rapidly multiplying bacteria, whereas the continuation phase attempts to eradicate slow, sporadic multipliers and persistent bacteria. Although 6 months is the duration of standard short course therapy, scenario regularly arise that require prolongation of treatment. During therapy, liver enzymes should be monitored monthly in those with a pre-existing liver disease, because all first-line agents except ethambutol can cause hepatic toxicity that can be reversed with drug discontinuation. Patients should be advised to abstain from alcohol and other hepatotoxic drugs. Although treatment is in general well tolerated, severe hepatic injuries has occurred. Visual acuity and red-green color perception also should be monitored in patient taking ethambutol. These are the second-line drugs that are being used for the multi-drug resistance tuberculosis: streptomycin, capromycin, amikacin, kanamycin, ethinomyde, levofloxacin, moxifloxacin, linezolid, and bedaquiline. Second-line agents are reserved for patients in whom first-line agents fail or who experience side effects from the first-line agents or cases of drug resistance. About 55% of the patients require surgery for the bilateral obstruction or the unilateral obstruction in solitary function kidney. They may need a DJ placement or the PCN for drainage. And for non-functioning kidney with recurrent TB despite optimal medical treatment or with medically resistant hypertension, they may need a nephrectomy. For ureteral strictures, endourological procedures or open surgeries can be performed. For tuberculous contracted bladder, augmentation, cystoplasty, or bladder substitutions are the available options.
Thank you.